Hello, ladies and gentlemen, and welcome to GCH 604 Fundamentals of Epi and Biostats for the fall 2022 semester. I am Dr. Renee Nahera, DRPH, Doctor in Public Health. I am not a physician. let's just get that clear off the top. Thank you all for joining us this semester. And I don't know if you can hear in the background, but the kindergartner, she is around. I have a 5-year-old, and it's the modern day working from home thing. Anyway, this week we're gonna give you an introduction, just a quick introduction to the course, what the course is about, what it is not about, a little introduction to myself, and I'll go over the syllabus, etc. So this is me right here. My name is, again, Renee Nahera. I am a medical technologist, master's of public health, and a doctorate in public health. I have he, him, his pronouns. I think that's important nowadays so that we are not caught in a situation where we call somebody by a pronoun that is not theirs. This was something that happened often with me with the name Renee. As you can imagine, it's, in the US at least, is more common of a female name, and so I always got emails returned to me with misgendered pronouns, and so that was a little bit embarrassing for everybody. So I think that's primarily the reason why I'm encouraged that more and more people are stating their pronouns. So now you know that I am a man. I identify as a man, and you can refer to me as he, him, his. All fine and good. I have a bachelor's of medical technology from the University of Texas at El Paso, a master's of public health and epidemiology and biostatistics from George Washington University, and a doctorate of public health from the Johns Hopkins Bloomberg School of Public Health. This is my phenomenal wife, Deanna. She is a physician assistant extraordinaire. She works in an emergency department. She works at a local health department, and she also does mental health at a university. And this is the kindergartner right there, Aubrey. She starts kindergarten this week, actually. I currently am an epidemiologist at the Fairfax County Health Department doing mental health and substance use programs. I also, during the COVID response, was the director or the branch chief of the long-term care response unit. So I directed nurses and epidemiologists as we were responding to COVID-19 at nursing homes. Very, very sad situation. A lot of death, unfortunately, a lot of illness in that population, and we were the ones responsible for responding to it. I am currently the editor of the History of Vaccines project as well from the College of Physicians of Philadelphia, but starting October 1st, I will be the director of the Center for Public Health at the College of Physicians of Philadelphia, leaving my position at Fairfax. So after 3 wonderful years at Fairfax, I am moving on to bigger and hopefully better things up at the college. So from the syllabus, contacting the instructor and office hours, you can email me. Please always email me. This is the best way to do it. And per school requirements, you must use the gmu.edu email address. If you use a different email address, what I'll do is I'll reply to you and remind you to please use your GMU address, and I'll copy myself on it on the GMU address as well. So please always use the gmu.edu address to contact me. Don't contact me via telephone unless we previously arranged a telephone call. For example, you're coming over to my office to do office hours. You might call me just to tell me you're running late or something like that. Do not contact me on social media. I am very active on social media. If you go looking for me, you'll find me on Twitter, Facebook, etc. But please do not contact me with anything school related on social media. And frankly, for the duration of this course, just so that we don't have any appearances of impropriety, such as preferential treatment because I like one of your posts or because I retweeted something that you tweeted out, let's just stay off of social media for the duration of the course. Of course, afterward, you can follow me. And then yes, do not email me to my email at work or my personal email if you have it. Do not. Everything should go through the gmu.edu. I cannot stress enough how important that is. Allow up to 24 hours for a reply. And then what I'll do is I'll do office hours by appointment only via Zoom. And what we'll do is we'll also record them because you never know when somebody might have a question that we discussed in the office hour. So if you need to contact me for something personal, during the office hour, then let me know. That way, we don't end up sending that video out to everybody. So we'll always be careful. But for sure, I will be recording office hours. Your assessments, you're going to have weekly quizzes. So every week you'll get a quiz, and you will you'll get the option of doing 12 quizzes out of those 13, or if you do all 13, what I'll do is I'll drop the lowest quiz score. Each quiz is worth 2% of the final grade for 24% total. Right there. Quizzes are open from the beginning of the week to the end of the course. So if I open the first week's quiz, will open this week, and you'll have until the end of the course. The ones that I open at the last week, you'll just have the last week of the course to get it done. So that's 24% of your total. 36% of your total will be the midterm exam. It covers the first half, the first 7 weeks of the course. 36% of your final grade. It'll open at 1 past midnight on October 10th. So the 10th in the morning, very early in the morning, and we'll close at midnight, close to midnight, 23:59 hours on October 16th. I will upload a walkthrough of the exam once I've done it. I'll also upload a walkthrough of the quiz, but only if everybody finishes the quiz. If not everybody's done, of course, I'm not going to do the walkthrough and upload it, because then that person that hasn't fixed, or those people who hasn't finished, will have the answers, right? And so we'll try to avoid that. The final exam is comprehensive. It's worth 40% of the final grade. It'll be open from 1 past midnight on December 14th and close at 23:59 hours on December 14th. So you'll have the whole 24 hours of December 14th to get it done. I'll upload a walkthrough of the exam on the next day, and that's 40% of your final grade. Now, a lot of students ask about extra credit. There's going to be extra credit in the quizzes and the exams. There'll be some questions in there that'll be for extra credit. But unfortunately, just because of the time constraints of this course, because it is online, etc., I will not give you any assignments as extra credit. So I'm sorry, there's no exceptions. I'll put plenty of extra credit in the quizzes and in the midterm and the final. I think in past years, I put up to like 10 points, 10 percentage points toward your final grade in extra credit. So plenty of opportunities to do extra credit. Just answer all the questions on the exams. Academic honesty. This is something that is very important. If you look over here, these are answers off of a website called Quizlet that students in the past used to answer some of the questions on the quiz. And they got caught. And they got caught because they basically copied and pasted the answers and then didn't say where they got them from. They passed them off, tried to pass them off as their own answers. And I caught on to it because I've been around, guys. I've been doing this for a while. And I have ways of running answers by plagiarism checkers. And so they got caught, and several of them ended up with an F for the course. Others got a lower grade for the course, etc. So don't do it. Just don't. If you get your answers online, don't copy and paste them. Answer in your own words and in full sentences. And if you're found in violation of the Academic Integrity Code, you get referred to the Honor Code Committee with a recommendation of an F in the course and a requirement of academic ethics course at your cost. No exceptions, no negotiations, zero tolerance. This is something that I take very seriously because it's serious things. It's serious stuff. You want to be honest and everything that you do. So please don't get your answers off the internet. Get them off the text, off the slides, off your notes, etc. It's just good practice. It's just very good practice. Okay, so we're going to be doing the course for 15 weeks. At week 7.5, you're going to have the midterm exam this week, the week of October 16th. That's when the assignment will be due. Remember, it opens on the 10th. You have 7 weeks here, the first half. Then we take the midterm exam. And then you do 1, 2, 3, 4, 5, 6 more weeks. And then Thanksgiving week, you get off. And then the summary lecture. And that's it. You're done. Then you take the final exam. So we're going to be working our way. This is the schedule. It's in Blackboard. So the topic, when the assignment will be, what the assignment will be, and it's a quiz for all of these. Other courses I offered actually writing papers, but it can get a little out of control when the class is online. Assignment will be due on these dates, and this is where you get the required reading from the text. Okay, everything comes off the text. The first 7 weeks are more about observational epidemiology. If you take a look at this, it's all observationals, describing things, and how John Snow described the cholera outbreak and how that led to the resolution of the outbreak, etc. The second half is more analytic. So how do you design a test to test if two populations have different levels of something? and also more biostatistics incentives. So the class is Intro to Epi and Biostats, and the Biostats really comes in the second half. I'll have additional lectures, so you'll have the regular lecture with the slides, and then I'll upload another little lecture about biostatistics, very basic stuff, and then I'll also upload R code using R. And what I'll do there is you can just copy and paste that code into your console and run it, and you'll see R doing about statistical work for you, and you can read the output. In the exams, or in the quizzes rather, and in the final exam, what I'll do is I'll put a piece of R code output, and then you just tell me what it is. Is it saying that the two comparisons are statistically significant or not? What's the p-value? What's the measure of comparison, etc., etc., etc. So you'll see as we go through this. You'll have instructions on how to install R in your computer, how to get it up and running, and then I'll also upload videos of me going through the R code that I'll give you. You'll see the videos of that. So very just sit back and relax and kind of look at what I'm presenting. I'm not asking you to come up with code on your own. I'm not asking you to learn R per se, just how to operate it. And so that's the biostats section in the second half. So the course objectives, and you have this in the syllabus, right? Calculate, interpret, and compare measures of disease frequency in populations, so things like incidence, prevalence, mortality rates. Describe key characteristics of epidemiological study design, like randomization. Why is that important? Why is it important for us to match cases and controls? How do we control for confounders? What is a confounder, etc.? So that'll be in the course. Interpret results of data analysis for public health, so odds ratios, risk ratios, incidence rate ratios, etc. Select quantitative data collection methods and epidemiological study designs appropriate for a given public health context. So if you have an outbreak, we use case control studies. Why? I'll explain that to you. If we're assessing vaccine efficacy, we do randomized control trials. Why? We certainly learn a lot about that with COVID, right? Analyze the quantitative data using biostatistics and computer-based software. So we're gonna use R for the computer-based software. And so we're going to ask questions of R, like if we have these two populations with different ages, are they statistically significantly different between the two populations? If people if people are of a certain weight, a group of people have an average weight, and then they all go and train for a marathon, and then we weigh them again, was there a significant difference? Hopefully a drop, right, before and after. And so what kind of analysis do we do, and why do we do it that way? And then also communicate the role of statistical inference in epidemiology and biostatistics. So if you notice this statement here, we found that the drug lowered cholesterol by an average 10 milligrams per deciliter with a 95% confidence interval of 6 to 14 milligrams per deciliter and a p-value less than, 1/10,000 in participants in the experimental arm compared to the control arm. Why is this written this way? Right? What does a 95% confidence interval mean? What does the p-value mean? Like, this is the way that you write in an article. So when you read articles, journal articles, you'll see these statements and you'll understand why they're written that way. So do not expect to be senior epidemiologists at the end of this course. A lot of students in the past have complained that they didn't feel like they were full-fledged epidemiologists at the end of the course. No, this is intro. This is for you to be introduced to the concepts. This is just an introduction. Don't expect to understand biostatistics in and out at the end of the course. Again, intro. Don't expect to be masters of data analysis with the statistical software, in this case R. Do not expect to be able to answer epidemiological questions at the end of the course. Again, this is intro. That's why you have the other courses hopefully in your studies. If you want to be epidemiologist, then you have to go through the Epi series and biostatistics series, etc. So, do not expect that, but do expect to recognize the study design needed to answer a particular question, to understand the caveats of those designs, to recognize the measures of association and disease burden. So when do we use incidence rate ratios? When do we use odds ratios? When do we use relative risk? Know why a comparison of those measures may or may not be statistically significant. And this is a thing that I always tell students: don't fall for the trap that just because something is statistically significant, it is automatically clinically significant or clinically impressive. And do expect to see the R code and know what to look to get an answer, right? If I give you the output of running an R session, a statistical test in R, expect to be able to read it and kind of understand what it's telling you. But as far as the programming, I mean, you'll learn it, but don't expect to be masters at it. That's why there's different courses on how to use R, Stata, SAS, Power BI now is using some of those things. So there's more advanced courses for that. This is all intro. Okay, and with that, we're going to go to Chapter 1, Foundations of Epidemiology. If you have any questions so far, there is the discussion forum where you can put questions, and I'd rather you do use the discussion forum. If you email me with a question that is applicable to the rest of the course or the class, I will put it in the discussion forum. So, and that's where you'll get the answer. So it's better to just put it in the discussion forum, and I'll answer there. All right. Okay, so this week, you should read Chapter 1, 2, and 3 from the Merrill textbook, the 8th edition. Foundations of Epi, Historic Developments in Epi, Practical Disease Concepts in Epi. Optionally, there's this really good optional free course called Principles of Epidemiology from CDC, and Lesson 1 is the one for this week. But it's optional. It fills in a lot of the history and background of epidemiology. Before I became an epidemiologist, I printed it out, and this was in the days when you couldn't download things. And I printed it out and from the website, and it was great. It's what encouraged me to become an epidemiologist. Okay, so what is epidemiology? It's the study of the distribution and determinants of health-related states or events in human populations, and the application of this study to the prevention and control of health problems. That's one of the definitions. Just the study of that which comes upon the people. So epi is upon, demos is people, and ology is study. So the study of things that come upon the people. Science-based and supported by different disciplines, right? Mathematics, sociology, biology, demography, geography, politics. A lot of things go into epidemiology. A full-fledged epidemiologist will understand a lot of things from a lot of these other disciplines. Understand them. You don't have to be a master of them. You have to understand them and recognize them, so that you can use things like sociology and demography to understand social determinants of health. So you use mathematics for your biostatistics. Geography to understand if you see clusters in space, hotspots on a map, etc. So this is what epi is all about. It comes in two flavors: descriptive epidemiology, which is observational. So you just sit there and you describe a problem. You'll see that in the John Snow cholera case study. Who, what, when, where, why, and how. Often we don't really understand why. Why do things happen to people? But we can understand who's being affected, what is affecting them, when are they being affected, where, you have the map, and how severely. So that's what this map is telling us. When was the week ending July 18, 2009, right? This is H1N1 type situation, the pandemic back then. Where is the United States and its territories? When, I just went through that. Where, how, how it's here is the severity. What? Well, we know it's influenza. And who is missing from here, right? We can say United States residents, but I would like to have seen in here something like different age groups, because different age groups are being affected differently by influenza. We know that, right? We also describe the frequency of the disease, and you usually see that in epidemic curves, right, over a certain amount of time, and the pattern of the distribution. Analytical, which is more research type epidemiology. You confirm theories on why a disease happens, how, why, when, where, and to whom through experiments. So you take two groups, a control group, an experimental group, or more than two groups, right? Control group, and then an experimental, and then some other experimental group, etc. You actually do research, and that's the analytical side of this. We try to understand causes and risk factors. Right? Don't be confused. There's a difference between causes and risk factors, right? So a cause definitely causes a disease. It's necessary, but sometimes it's not sufficient. Necessary and sufficient are things that are discussed in the book. Here I'm just going to give you an overview and some examples. So necessary and sufficient: HIV causing AIDS, right? You need to be infected with HIV to definitely get AIDS. It may not be sufficient if you were taking antiretroviral therapy. So nowadays, people can get on PrEP before they're exposed or on post-exposure antiretroviral therapy. and not develop HIV, AIDS, full-fledged AIDS. And AIDS used to be, or HIV infection used to be a death sentence. Not anymore. You can live a very normal life while infected if you take your antiretrovirals. But to get AIDS, you need to have HIV. No HIV, no AIDS. That makes it both necessary and sufficient if you're not taking the antiretroviral medication. Necessary but not sufficient, sunburns and skin cancer, right? If you don't get sunburned, you don't get skin cancer. There might be other causes of skin cancer, and that's what you kind of assess in epidemiology. Somebody who gets a lot of skin burns and doesn't get skin cancer versus somebody who does get a lot of skin burns and then develops it. What else was going on? Cancers have genetic components, that could be necessary for a specific kind of cancer, but not enough. Just because you have the gene doesn't mean you're going to develop cancer. There must be something else. So that's an example of something that's necessary but not sufficient. Recently, the novel coronavirus causes COVID-19. There's plenty of asymptomatic people, but also plenty of exposed but not infected. Right? Time and distance to be exposed but not infected. So just understand from the book the differences between necessary and sufficient. Risk factors that increase the chance that a disease is acquired, right? Risk factors are not causes, so pay attention to that. Hint for your quizzes and your exams. A risk factor is a behavior, environmental exposure, or inherent human characteristic that increases the chance of developing an adverse health outcome. Individual, environmental, social, political, and economic risk factors or things that can cause disease. But again, they're not causes all by themselves. Sometimes it could be. You can have a risk factor that's also a cause for disease. But just by themselves, they're usually not causes. So in epidemiology, we identify those risk factors. We describe the natural history of disease. We identify individuals and populations at greatest risk for disease. We monitor disease and other health-related events over time. We evaluate the efficacy and effectiveness of interventions. We participate in health planning. We manage health programs. We communicate, and we have other duties as assigned. Think about monkeypox, right? Identify risk factors. Well, right now, based on the epidemiology, and this is August of 2022, the epidemiology is telling us that men who have sex with men are at the highest risk of getting monkeypox. Everybody can get monkeypox. Nobody's immune unless you got the disease already or you got the vaccine. But the risk factors right now, based on the epidemiology, is men who have sex with men. And that's why men who have sex with men are being prioritized for the vaccine, because there's not enough vaccine to go around. If there were enough vaccine to go around for everybody, then we wouldn't worry about the risk factors, right? We would just vaccinate everybody. But because we have limited vaccination, we go with the epidemiology and prioritize those groups. We describe the natural history of the disease, and that's when you get this whole thing of like when you're exposed, up to 21 days later, you could be symptomatic or be asymptomatic and then develop the rash, blah, blah, blah. Identify individuals and populations at greatest risk. That I already talked about that. We monitor the diseases. You see the dashboards, you see the case counts, that's monitoring not only monkeypox, but the severity. This is all in disease surveillance. We evaluate efficacy and effectiveness, so vaccination, communication, all those interventions, we evaluate them. We help in health planning, so plan out campaigns, plan out programs. We sometimes manage those programs, and then we definitely communicate. I've definitely been in been interviewed a lot lately over monkeypox, and before that COVID, and before that other vaccine preventable diseases. So when we're looking at cases of disease, so a case is an individual with a particular disease or condition. And here, what I want you to take away from this part of the book and this part of the lecture is case definition. And case definition is a criteria used to identify a case. It can be very broad, so anybody with a cough and a sore throat and a fever is a case of influenza-like illness. That's very broad, right? That can be just about anybody. But it can also be very narrow. A child living in Virginia exposed to influenza in the last 7 days, exhibiting cough, sore throat, and fever with a negative test for any other viral respiratory infection. That's very narrow, right? And usually, ideally, case definitions have person, place, and time. So we have place, Virginia. We have person, a child. And then we have time, 7 days. And it is very, very narrow in this case. We can also have it very broad. We have different classifications. So a suspect case You have one definition. A probable case, you have a different definition. A confirmed case, you have a different definition. Usually, the confirmed cases include some sort of laboratory, objective, not subjective, some objective measure of disease status, and the other ones are more subjective. So, for example, influenza. A confirmed case is somebody who tests positive for influenza. A probable case is somebody who has influenza-like illness and they were exposed. And a suspect case might be just somebody who has influenza-like illness. They're suspect, but they're not fully down the track. The first case in the population to be identified, the first case in the population, identified or not, is the primary case. And then the index case is the first identified case in the population. Sometimes it can be the same person. And then secondary cases are a person infected from a primary case. So if a population being my home and I'm the one who comes in here with COVID, then I am the primary case. And then if my wife catches it or my daughter catches it, and this actually happened for real a couple of months ago, then they are secondary cases. And I think it was the child who brought it in, and then we were the ones who caught it. The book also talks about the epidemiologic triad: host, agent, environment. And then recently they've included the vector. But this is the triad right here of infectious disease. So the agent is what causes the disease, like the virus or bacteria. The host is the one who harbors the disease or can get the disease. And the environment, it's a little bit tricky because the environment can be just about everything, right? If you think about COVID-19, the host can be a human, the agent is the virus, and what is the environment? So it's usually like the air you share, right? And we found throughout the pandemic that it's not necessarily surfaces like we used to think, but it can also be surfaces. Same thing with monkeypox. The hosts are the people with monkeypox. The agent is the virus, and what is the environment? Well, it could be sheets. It can be inanimate objects like sheets, bedding, clothing, etc. You can also have vectors, right? So you can have, if you give monkeypox to a rodent and then the rodent goes and gives it to somebody else, then that is a vector. Okay. Typhoid Mary, if you don't know her story, read up on it. I believe it is one of the case studies, but very interesting situation here where a carrier state was first identified. It was the first time that scientists really identified and explained what somebody who is a carrier, who they are. A fomite is an inanimate object, like a needle, syringe, or a door handle, or PPE that has been used and thrown away. A fomite, again, inanimate. That is the inanimate. I can't spell, guys. Inanimate. If it's inanimate, not alive, then it's a fomite. If it's alive, then it's a vector. If it's alive and it carries a disease but it doesn't get sick from it, then it's a reservoir, right? Swamps and mosquito-borne diseases, birds and avian influenza, humans and measles, bats and coronaviruses. Those are the reservoirs. And the virus just it's living in there all the time. That's where it reproduces. That's where it multiplies. That's its natural environment. It's a reservoir. A carrier carries the disease and the infectious agent transmits it, but it's not ill. But in a carrier, the virus might not be continuously multiplying. And you have these different things here: an active carrier, a convalescent carrier, healthy carrier, incubatory carrier, intermittent carrier. Typhoid Mary, if you look at her story, she was definitely intermittent. It wasn't all the time that she was giving people typhoid fever, but when she did, man, she did. So take a look at the case definitions. At the definitions for all of these things. Inanimate, know how to spell it, and those are big hints for your quiz. Modes of transmission: direct and indirect. Direct requires physical contact, like STIs, like Hansen's disease, otherwise known as leprosy, that's mycobacterial infection. So that's, you need to be in direct contact. Indirect are things like airborne, vector-borne, or vehicle-borne, fomite-borne kind of infections. So know the difference between the two. If I give you an example in a quiz, tell me if it's a direct mode of transmission or indirect mode of transmission. And here we obviously have indirect mode of transmission. This is the classic picture of somebody sneezing. Look at the malaria life cycle, for example, right? Mosquito, which is a vector, right? An arthropod, a vector, will bite you and give you the parasite. parasite multiplies inside of you. Now you become the host, right? And once you get the parasite and then it bites you, it takes in the parasite again. So now this mosquito is not only the vector because it's transmitting it, it can also be the reservoir of the disease, right? Because it actually goes through some sort of maturation stage and becomes a reservoir and then the vector, and the cycle repeats over and over again. So I will put some of these life cycles in some of the exams. Pay attention to them and tell me, if I tell you here, what is a human in this example? The host, right? What is a mosquito? You can tell me vector or reservoir. What is the agent? The agent is the malaria parasite. What is the environment? It could be the swamp, right? It could also be the garden or the standing water in the garden, etc. The chain of infection. So the triad has morphed over time more towards the chain of infection. It looks, you have the same things as in the triad, right? You have the agent, the host. You have the mode of transmission, which would be kind of the vector. You have the reservoir, the portal of exit, portal of entry. So let's look at flu, right? The flu virus is the infectious agent. Humans are the susceptible host. Portal of entry would be maybe your respiratory system, right? You breathe it in. Mode of transmission is airborne, so indirect. The reservoir could be birds, right? For type A flu. And then how did it get out of the birds to be airborne? Maybe you needed an intermediate host, but in any case, it's also respiratory. Right? You can, if you eliminate one of these, then you can get rid of the chain of infection. If you get rid of flu, obviously you get rid of flu. If you get rid of the reservoir, then there's no chance for the flu to then jump onto us. If people wear masks and stay away from each other, then the mode of transmission is eliminated. If you cover your face, then the portal of entry is eliminated. And there are some drugs that also prevent the virus from actually attaching to your respiratory cells. So that would also be another way of doing it. And if you get rid of humans, well, that's not what this class is about. Prevention. We have prevention. Primary prevention, active and passive primary prevention. This is prevention that is done before the disease happens, like immunization. So before you're sick, you're giving a vaccine, right? It's active because you actually had to do something, which was get the vaccine to prevent it. It's not passive because you're not doing something like it's hard to read the book, but it's hard to explain. Like keeping people away from each other. You don't have to do anything. You just kind of stay away from people, and that's passive. Washing your hands is active, right? You actually have to wash your hands to prevent. But again, the main thing here for your quizzes and your exams is that primary prevention is anything that is done before the disease happens. Secondary prevention is anything that is done when the disease is underway, but it's not yet showing. So people who have diabetes or people who have high blood pressure may be asymptomatic. They might not know that they have these conditions going on and they're not showing any signs and symptoms. Secondary prevention in that case would be to screen them. And if you screen them and you find out that they are diabetic or have high blood pressure, you can give them medication to stop the disease and reverse it right then and there, right? There's no damage done. They're good to go. Tertiary prevention, the disease has started to show, they're already getting signs and symptoms, damage has been done, and you give them medication to prevent the poor outcomes as much as possible. And it may be possible to reverse it a little bit, but in some cases it may be not possible. So, you can see these things as people who use substances. Somebody who uses heroin, for example. They already used the heroin. They're already infected with hepatitis B. They were not vaccinated, so there was no primary prevention. They are showing some liver damage, so secondary prevention cannot be done. But maybe you get them into some sort of rehabilitation program where they're not using substances anymore. Their liver doesn't get damage beyond the damage that has already happened. You put them on some sort of medication to kind of protect the liver henceforth, and that would be tertiary prevention. So for your exams and your quizzes, know the differences between primary, secondary, and tertiary. I might give you an example of them, and then you tell me if they are primary, secondary, or tertiary. History of epidemiology, some historic moments, and this is very fast. You'll be reading about them, you'll be doing the case studies, describing what's going on and who's being affected as far back as Hippocrates, maybe even further back. Jon Snow, there was uh, uh, a Middle Eastern scientist whose name embarrassingly escapes me right now, who in 910 described the difference between measles and smallpox. I want to say it was Razes, but basically, the when scientists started describing things and telling us all about them, that's when science really started picking up, right? And then we have confirming theory. So Edward Jenner had theory that the vaccinia virus, which he didn't know existed, it was just some theory of his, could prevent smallpox. Louis Pasteur had a theory that germs didn't come out of nowhere, and he confirmed it. And now we have germ theory. Robert Koch also had a theory about microbes, and we confirmed it, and so we have Koch's postulates. A history of communicating, John Grant, how to communicate disease concepts. Cases that taught us something, Typhoid Mary's case, Florence Nightingale and her infection prevention pioneering, and then the studies that gave us the knowledge, the Birmingham Heart Study, the Jane Lane Clayton studies. So things that give us the knowledge. And so just look to those in the book, read about them. I'll toss in a couple of questions here and there. These are just historical moments. I'm a history geek, even though I unfortunately forgot the gentleman's name from 910. I'll look it up and maybe mention it in another lecture. But this is just important to know the background, right? And everything didn't happen all at once. It took 100, 200, 300 years. We've been with vaccinations for 200 plus years and are still having people who are vaccine skeptical and people who are vaccine deniers. So it's a lot of work over a lot of time, and same thing with epidemiology. And then practical disease concepts from chapter 3. So is something communicable or not? Just because something is infectious, it doesn't mean that it's contagious. Contagious means that it can be given from one person to another. If it's infectious, it means that the pathogen infects you and causes a disease state, right? Infectious and contagious, influenza, COVID-19. Infectious but not contagious, tetanus, Legionnaire's disease. You cannot give another person tetanus, person to person, or Legionnaire's disease. Non-infectious and non-contagious, cancer of the prostate, right? It's a disease, but it's not infectious and it's not contagious. And non-infectious, but it is contagious, violence or conversion disorder. Conversion disorder you typically hear when people are being hysterical. Everybody start laughing and nobody can stop laughing because the laughing is contagious, right? So things like that. Vertical transmission, mother to child, or genetic disorders. So vertical, mother to child, right? Mom to baby. Genetic disorders. Horizontal transmission, person to person, vector-borne, vehicle-borne, right? Vehicle-borne in animate. So just think of these concepts. If I give you an example of a disease, if I tell you, for example, monkeypox, is it infectious and contagious? If I tell you about that epidemic of laughter or an epidemic of dancing, apparently was reported at one point. Is that infectious or contagious? And not infectious, but it is contagious. So those are the kind of questions that will come from this. Understand the differences. But basically it boils down to, if it's infectious, it's an infection that you get. It's some sort of an agent that infects you, causes a disease state, you get sick. Contagious, you can then pass on that agent to somebody else, right? If it's not contagious, like tetanus, you have the Clostridium tetani, comes into you, creates a toxin, gives you tetanus, where you're lockjaw, you're paralyzed, but you basically cannot pass it on to somebody else because it's a toxin. It's not like you're going to infect somebody with a toxin. Legionnaire's disease is a bacteria, Legionella pneumophila, found in basically anywhere where there's water, natural water source. You get a pneumonia from it, but we have not recorded cases of somebody coughing it out and giving it to somebody else. It just doesn't work that way. Okay, so those are some of the examples that I'll give. Vertical transmission. What could be vertically transmitted? Could HIV be vertically transmitted? Yes. Mother with HIV can pass it on to their child either at childbirth or through breastfeeding, right? Genetic disorders, father to child. The father has some sort of genetic disorder, passes on to the child. That's vertical transmission as well. How do we prevent those, right? Screening. What's screening? That's secondary prevention, right? Those kind of things I want you guys to start thinking about when we're talking about disease concepts and how to do the epidemiology of those diseases. Horizontal transmission, pretty clear, person to person, vector-borne, vehicle-borne. So a pathogen is, according to the book, an organism or substance such as a bacteria, protozoa, virus, fungi, or abnormal or infectious prions, proteins produced by mutated genes, and parasites that are capable of producing disease. Right? Pathogens produce disease. That's what you need to know. Here's an organism. Does it produce disease? Yes, it's a pathogen. Infectivity, it can infect. It can enter you and multiply. And that's the infectious. Remember, we just discussed it. And then pathogenicity is can cause disease. Just discussed it. A pathogen causes disease. Virulence is how bad the disease can get once it gets started. So one of the things to know here is that something can be pathogenic but not very virulent. So think of the common cold, right? Common cold, you get it, you get over it in a couple of days. Kind of happening now with COVID, right? If you're vaccinated or have had it before. Pathogenic but not very virulent. Pathogenic and extremely virulent. Think of Ebola, right? Ebola, you're a goner unless you get some really high level care. Rabies, once it sets in, that's it. You're done. Nobody survives rabies. So very virulent things, pathogenic. There can also be some things that are not pathogenic, like normal body flora, right? You have some bacteria all over your skin. They're not causing disease. They're not infecting you. They're not pathogenic. Are they pathogens? Yes, because they could cause disease, but they're not causing the disease at the time, and at that time they are not pathogenic. So, okay, natural history of disease. There's a time between being susceptible to an infection and then being healthy, and then after you're after you're sick and you recover, or if you get vaccinated, you can be immune. So really, you have susceptible and healthy, and then immune in this situation. Pre-symptomatic, you were infected, but you have no signs and symptoms. There's no damage done to you. So, for example, measles, the first 10 to 12 days, you're pre-symptomatic. The incubation is when you have infection, the time from infection to symptoms. So you have it here in this graph, your incubation period. Right, this was the moment of infection up here. Your incubation period, you don't have any signs and symptoms. But then the disease comes in. That's when the incubation period ends. The latent period can be any time before detection. It doesn't have to be by the time of disease, but any time before detection. So, for example, tuberculosis. A lot of people have latent tuberculosis. They're infected. The mycobacterium is in their lungs, and then they get screened to go to school, or they get screened to go abroad. And here they discover that they have tuberculosis. Now they need treatment. So they don't even need to get to the disease state to be detected. That's your latency period. And then period of communicability is when you are communicable, when you are infectious to other people, right? And so we learned that with COVID. It's a moving target, still learning about it. But just think of these concepts. If I give you a similar graph, would you be able to fill it out? Or if I tell you, for example, John became infected on the 1st of July. He went and got a test on the 4th, and it tested positive. What was the latent period? Well, it was from the 1st to the 4th. John got infected on the 1st. He developed symptoms on the 7th. What was the incubation period from the 1st to the 7th? John got infected on the 1st. On the 4th, he had a close intimate contact with a partner, and that's when the partner got infected. What was the communicability period? Right? Well, we don't know the end of the communicability period, but we know where it started, and it was on that time. So, et cetera, et cetera, et cetera. So just understand these things and how they're defined. And then you have clinical disease and recovery, disability, or death. So you either recover from the disease, it disables you or not, or it kills you or not. Hopefully it doesn't kill you. Hopefully any kind of disability is not long term and can be reversed. And hopefully you recover. Zoonosis. This is something that a lot of students have struggled with in my infectious disease course. If you took that with me, a lot of students had a hard time understanding what a zoonosis is. A zoonosis is any infection that can be transmitted from animals to humans through direct contact. Right? Any disease. If an animal had it and then you got it, it's a zoonosis. No, there should be no exception. Some students were like, well, what if that disease is not normally found in an animal, and then an animal got it from a human, and then the animal gave it to another human? Zoonosis. Okay? It's even if it's not normally known as a zoonotic disease by the common definition, If an animal gave it to a human, it's a zoonosis. It can be incidental, like people eating bushmeat and getting infected with Ebola, for example, or in the wet market in Wuhan, China. It's an incident. It can be accidental in the lab. You're handling a rabid bat, and you get exposed to it that way. Okay, rabies, plague, Ebola, and coronaviruses are examples of zoonosis. So if I tell you that Jim was out in the field and he killed a rabbit, and in killing the rabbit and preparing it to eat it, he contracted tularemia. Is that a zoonosis? Yes or no? Okay, so those are the kind of questions. And of course, you can argue that they're not, but if an animal gave it to a human, it's a zoonosis. Notifiable diseases. So every year, the Council of State and Territorial Epidemiologists, known as CSTE, go to their website. It's really neat website and organization. They have student rates if you want to join. They meet yearly and they discuss which list of diseases should be communicable. Should be notifiable. And then they go back to their legislatures in each state and territory, and they say, hey, we need to add or we need to take away this disease from this list. And the legislature passes it. In some places, in other places, the health secretary has the authority to put it on the list or taking it off the list. And in some places, they just say whatever CSTE says, that's what's on their list. They don't even bother with debating it. They trust the science. And so every year, this group of epidemiologists get together, and they set the list of recommended diseases that should be notifiable. What does notifiable mean? It means that a healthcare provider or a laboratory tech or a teacher or the captain of a ship, as soon as you hear of a case of whatever that disease is, you need to notify public health immediately. Some states can give you 24 hours, 72 hours to report. Others say no, as soon as you find out. So, for example, if you're a teacher and you see a kid with a fever and a rash, in some states that's reportable. You need to get on the phone and contact public health, because that could be measles. You could be in trouble. Your class could be in trouble if they're not vaccinated. So immediately notifiable. So anyone and everyone with knowledge of the disease, ideally physicians, physician assistants, and nurses, healthcare providers are the ones who or get to report, because they can diagnose and understand these diseases. But basically, in a lot of places, it's everybody. Laboratory masters of ships, etc. Other concepts, immunization, right? We certainly learned a lot about immunization over COVID-19. I won't have you dive too deep into it, but basically you give somebody either a protein or the whole cell, the whole pathogen in a killed way or in a weakened way, so that they have some immunity against it or develop immunity against it without getting the disease, right? Herd immunity is when enough of us in a herd, in a group, in a community, we now call it community immunity, are immune, so that people who are not immune because they cannot get vaccinated, their immune system is too weak, the disease doesn't have a good chance of getting to them. So when herd immunity kicks in for COVID, for example, we're still going to have cases, but we're not going to have outbreaks. We'll see cases, sporadic cases here and there of COVID, but we're not going to have outbreaks at schools. We're not going to have outbreaks at nursing homes, daycares, etc. It'll be just like the common cold now, right? Like, you don't really see outbreaks of it. You just see people coming down with it, and they get better quickly. They don't even show symptoms in many cases, right? It just goes away. Environmental controls. So when you're trying to control disease, and this is more for an infectious disease course, you can set some environmental controls, such as negative pressure rooms to keep air flowing into the room and not out. This is very, very important for things like tuberculosis. Those are the kind of environmental controls. And then host-based controls are like telling people to stay home, telling people to stay 6 feet apart, to wear a mask. You're setting a control on the host and the person that's infected. So to close out, there's different versions of public health. Public Health 1.0 was all about infectious diseases. Here we're talking the 1700s to the 1800s, or maybe even the 1900s. It's all about infectious diseases and controlling them. Potable water, sanitation, immunization, antibiotics, antivirals, infection prevention and control. Public Health 2.0 is all about chronic diseases, cancer, obesity, because once we took care of infectious diseases, there were not as many cases, at least in the United States, and what kicked in? There were more and more people living longer. And living longer means you have a better chance to overeat, to be exposed to the sun, to be exposed to chemicals. And so things like diabetes, heart disease started appearing at a higher rate, cancer, injuries, etc. So Public Health 2.0 focused on those chronic diseases. Public Health 3.0 said, hey, sometimes it's not necessarily that you have something wrong with you. Sometimes it's society that's causing these things. Discrimination, low wages, living in a bad part of town that exposes you to chemicals because some company wanted to make money off of the land, even though the land was contaminated. These kind of things. You're living in an overcrowded setting because of your culture. You like to have grandma and grandpa living with you, and aunts and uncles and cousins, that kind of thing. And so Public Health 3.0 is looking at diseases and the social determinants of health, and I mean all diseases, not just infectious diseases, not just chronic diseases, but all diseases. And Public Health 4.0 is coming, and we don't know exactly what it's going to be. It looks like I'm betting on big data, but also globalization. Maybe if we can get our act together and work as a world to try to prevent diseases instead of kind of disjointed, kind of like how we did the pandemic. Climate change is definitely going to be in the mix. We are seeing it already. If you've been outside, you know. Health equity, and everybody having equal access to health and preventive measures, primary, secondary, tertiary prevention. Or is it going to be something else? Who knows? We'll see. So week 1, your quiz, read the glossary and understand the definitions. I give you an example of a disease condition. Tell me if it's communicable, chronic, infectious, pathogenic, virulent, etc. I talked to you about this in the lecture. If I give you an exposure, is it a cause or a risk factor? Right? Smoking, is it a cause or risk factor for lung disease? Poverty, is it a cause or risk factor for COVID-19? Ebola, is it a cause or risk factor for hemorrhagic fever? Are they necessary, sufficient, or both? And then if you can answer the study questions at the end of the chapter, you're good. You're good to go. All right. And again, if you have any questions, put them in the discussion forum. And yes, I know this is the Spanish question mark on the left hand side. If you have any questions, put them in the discussion forum because I think you're not unique in your questions that you have. Other people might have them. I hate to answer 10, 20 emails about the same thing. I'd rather put it in the discussion forum unless it's a personal question or something that you definitely it's just about you in the class. Then do email me with that question. But if you have a question about the lecture, about the material, about some of the concepts, then put it in the discussion forum. We can discuss it further. Okay? And with that, thank you so much. Have a great week, and we'll be in touch for the second week lecture.